So I am delighted to be chairing this event. I think I told you my name is Rachel. It's pretty early in the morning, and I'm the Chief Executive of the Patients Association. And today we'll be focusing on a critical issue that research has identified around poor communication. And of course, we'll be focusing at the beginning on poor communication. The webinar today is about looking at what those solutions could be to improve some of the communication issues that patients experience. We believe that good communication is not just a nice to have, and it's a fundamental function to the NHS. And in the next hour, we'll be hearing from our wonderful panel who will share their insights, experiences, and recommendations. And we will explore those challenges that patients have experienced around poor communication. Communication, I think, is the cornerstone, like I said, and it fits so much with the Patient Association values of patient partnership principles. So first of all, I'm going to ask our panel to quickly introduce themselves so everyone can see who's here with me. And then I'm going to come back to Miriam, and she's going to outline a report that was done by Demos. Miriam, can I ask you to introduce yourself first?
Of course. Good morning, everybody. My name is Miriam Levin. I'm the Director of Participatory Programs at a think tank called Demos.
Brilliant. And next on my screen to introduce themselves is Matthew.
Good morning, everyone. I'm Matthew Riley. I'm up in West Yorkshire and I'm a patient and a carer.
Brilliant. And Raj.
Good morning, everyone. My name is Raj Patel. I'm a planner by profession, but I'm here purely to provide a patient perspective on communications.
Well, can I thank all three of you for attending and being here early this morning with me as we made sure we were ready. So, Miriam, I'm going to go back to you about the Demos report about I Love the NHS, which looked into patients' experience with NHS communications. Can you tell us, first of all, a little bit of a background to how you engaged with people about the report and a little bit more about the report?
Yeah, of course. I thought I'd start with the title. So we called the report I Love the NHS, and the reason we called it that is that we did a huge number of conversations with groups of people all over the country, about 100 conversations involving about 700 people, all about the NHS and social care and what people's experiences were and what they thought was working well, what they thought wasn't working well. And over and over and over again, what people said as they came into this conversation was, I love the NHS. I love it. It's amazing. I value it. I appreciate it. We're so lucky to have it in the UK. And then they'd go on and talk about these terrible experiences, really, really difficult, traumatic, frustrating kind of experiences that they'd had. But it always starts with, I love it. I'm going to tell you I love it. I can't possibly say that I don't love it. And the but that followed that was the thing that kind of crystallized in the report. So it was the thing that came out over and over again that people told us about was that the NHS doesn't communicate well. It just doesn't. It hasn't worked out really well how to make sure that patients feel like they know where they are in the system, they know what to expect and when to expect it, they know how they're going to be communicated with. So many times these systems, the back office system, the administrative systems just don't work really well. So that became kind of like the core of a large piece of work that we did over about a couple of years. So essentially the report, I Love the NHS, but it's about those everyday harms that are caused by the way the NHS communicates with people. So what was so interesting is, like, whenever I've talked about this, and I've talked about it with friends, with family, and with politicians, it turns out everybody's got a story about the NHS not communicating well with them and just feeling really lost in the system. So everybody, literally from the MPs we spoke to my best mate, they can tell me about, they don't know who to chase up to get a referral. Like the doctor said, the GP said, look, I'm going to refer you on to a specialist, and referral never comes through and they don't know who to call. They don't know what to do about that. Or missing critical appointments because a letter doesn't turn up on time. People talked about having to repeat your story about whatever the problem is over and over and over again to different specialists, to different clinicians, because nobody ever seems to read the notes. And there might be really good reasons why that is a thing that happens, but people still feel like no one's listening to me. You haven't heard me. You're making me re-traumatize myself by saying this stuff over and over again. And just one of the big problems was about that the connection between primary care and secondary care, where referrals go astray and the connections aren't made, and really people don't know who to call to try and sort any of this out. So we heard all these experiences from people, and then we thought what we need to do is we need to just find out, well, are these anecdotes? Are they something that people, that a lot of people across the country recognise? So we did a national poll that involved over 2,000 people, and we asked people about their experiences, and it turns out that 55% of the people that we polled said they'd experienced poor communications, like the sort of things I just referred to from the NHS. But one of the problems that we kind of identified is that while it's something that everybody experiences, or not everybody, but a huge majority of people experience, it doesn't make the headlines. It's not really talked about. It's not as obvious and as, in a way, easy to visualise as ambulances queuing outside A&E, or kind of huge waiting lists that are like top of the news or top of the political agenda. But it is these kind of daily frustrations that people feel when the administrative system just doesn't work as well as it should do. And sometimes it is really harmful. It is much more than just frustrating. Kind of people have felt it kind of at both ends of that spectrum. And what we think is that it should be something that is talked about much more, much kind of higher up the political spectrum. So just to give you a little bit more background into kind of how we got kind of to the work that we did, the reason we focused on it, we wrote kind of this big report on it, is that after we had our conversations across the country with about 700 people, we brought 100 representative people who represented the demographics like age, gender, ethnicity, disability or not, kind of represented the whole country. We brought 100 people together who kind of represent all those demographics. And we spent 4 days together talking about all the things that are going wrong in the NHS and social care. What are the most important issues to focus on? Because we can't tackle everything at once. We can't, government can't, NHS can't. And after 4 days of discussion and deliberation, the group came together and said, right, number one issue is there's not enough social care and health staffing. It's like, absolutely, could have expected that. That is a critical issue that everybody could recognise. But their second issue of all the many, many, many things that are kind of difficult and not going well in the NHS, they said the second one was poor communications between the NHS and patients. So that's really, that kind of crystallised it for us. So we're like, okay, we're really going to focus on that kind of over the next couple of years. The reasons that they gave for kind of saying that this is a priority is that they said that not only themselves, but from the testimonies that they heard, kind of our Citizen Assembly panel that we brought together, I said the poor communication results in delays in people receiving the care that they need. It wastes money and time, both for patients and for staff. It endangers patient safety. It's bad for people's mental health, like the weight, the not knowing. People said that it's really, really bad for our mental health. And it also increases the burden on already overworked staff. The point is, it isn't, thank God, usually life or death, but it is these everyday harms that most of us have experienced about not knowing who to chase to call, like call to chase up for an appointment, not being treated like a whole person. People say, look, we understand the NHS after COVID, there's waiting times. We get it. It's hard, but it's okay. But please tell me how long I'm going to have to wait. Just tell me I haven't been forgotten while I'm sitting on this waiting list. Because right now, I don't have any confidence in that. I don't know that you aren't going to have totally forgotten about me. I don't know if I'm ever going to get an appointment. And then when we polled people on that, kind of the national poll, 17% said that they hadn't known whether a referral made for them had been lost. Like, was it actually ever going to turn up? 18% said they didn't know who to contact about care or treatment once a referral had been made. 26% said they had to chase a referral themselves to make sure they actually got seen. And those numbers might seem, those percentages might seem low, but that adds up to millions of people across the country. And one of the problems that we kind of identified is that all these kind of small frustrations and negative experiences, they really drive down trust and confidence in the NHS. So 45% of people said it made them worry when they've experienced poor communications. It made them worry about the quality of care that the NHS provides. And 31% said they worry that NHS money is being wasted. It just made people feel like, look, if you can't even get me a letter on time, like I feel like I can't trust this system the way I used to. And we also found that poor communication disproportionately affects some groups more than others. So disabled people, people with long-term health conditions, women are more likely to report being affected by poor communications. So, for example, 22% of men said they had to chase up a referral to be seen compared to 29% of women. staff also told us that it affects them as well. So if you don't invest in back office staff and administrative functions, then clinical staff have to take on those jobs, which isn't a really good use of their time. It's like, I don't want the doctor to be chasing up a referral. I don't want the doctor to be doing that. I really want them to be focused on patient care. But even though it affects so many people and it can lead to serious, even life-threatening issues, it's not on the government agenda. And that's something that we're really, it feels really important, the fact that it isn't being talked about. I'm not sure if that's just because they don't think it is a public priority, even though we've heard from kind of all these thousands of people that it really is a priority. I think it's often easier for politicians to focus on institutional reform and like creating integrated care boards. And these are not bad changes to the system. They're often really helpful, good changes to the system, but they don't actually change the patient experience and actually change the things that people want to be changed. In a way, changing communication, improving communication could be in some ways an easier fix than massive rewirings of the whole kind of system diagram. But that isn't what people focus on. And what we heard is that people were saying, look, I don't care where the letter comes from. I don't care if it's from the hospital or the integrated care board or the kind of clinical commissioning group or the primary healthcare trust. Just tell me my appointment is coming and where I have to be seen. I don't really care about the rest of it. But it isn't on the political agenda at the moment. I've got lots of stories that people share that I can come back to those kind of like specific anecdotes or stories that people shared with us. But I'll finish there. We can come back to that in questions if that's helpful, Rachel. But the only thing I wanted to say is that it's not all doom and gloom. The second part of our work was all about looking at solutions, which I won't go into here. I know we're going to come back to those in a minute. But it's worth saying that what we did find was kind of those brilliant bits of the NHS that are doing it really well. And it was just a matter for us to think about, okay, so what are those? Where is it working really well? And how can we build on those? Because it can't be that hard to sort out getting a letter on time.
Exactly. And Miriam, we absolutely are coming back to solutions, and we'll come back to you to do that. And I think, I know the Patient Association gave you quite a lot of information for I Love the NHS But. And I think some of our helpline staff are on this webinar today as well. And I know through listening to their experiences that quite often the crunch is around that communication, about finding out. And I remember speaking to one person who was waiting for a knee operation, and she was saying to me, well, if I know they're going to contact me in 3 months' time, even if I know it means the operation isn't in 3 months' time, I just need to know that I haven't been forgotten. And I think it does, you know, if you're sitting waiting and you haven't got that information. And the other bit that we, another piece of work that we did with NHS England was around people who missed their appointments, that horribly termed do not attend. And again, it was about who to contact, who to talk to, and primary care talk about the impact on them as well, with people coming back going, I don't know. So I'm going to come, Raj, first of all, and ask you to reflect on your experiences and what you just heard from Miriam there.
Okay, thank you very much for that. Yes, I'm going to concentrate aptly between the two operations that I've had. The first one in 2022, which was my right knee replacement, and the most current, which was a matter of 6-7 weeks ago. So I think within that period, I'll be able to gauge whether there have been significant improvements in service delivery. I'm going to try and concentrate on just two particular aspects. The initial contact, which is always via written correspondence in some format, whether be it letter, text, email, or any other form of written correspondence. And secondly, the face-to-face interaction within the hospital clinical environment. So those are the two areas that I'm going to concentrate on. And I'm going to just highlight, my personal experiences, and people may beg to differ in terms of what I'm saying. I think there has been an overall improvement in the way correspondence is sent, and I'll clarify that. I think the letter format, which is quite important, it's improved to the point where it's written in plain English, in my opinion. It's clear, concise, and precise, and easy to decipher, unlike letters that we received in the past. So it's easy to get to grips with in terms of what the content of the letter is. It's clearly laid out. The do's and the don'ts are very clearly kind of bulleted. I think the drafting of the letter is important because when you open the letter and you see automatically a different use of fonts, different typefaces, highlights in bold and much bigger fonts, the key aspects, for example, the date, the time, the location, the speciality, the consultant, all these lift out and, almost are there. So you don't have to physically read through the whole letter to get at the various key bits of information. And I think that's critical. And I think that's important because you've got the information to hand, and particularly the contact point. Who do I need to contact if I need further information and advice? So I think the drafting of the letters have improved significantly. And in my opinion, it's easy to get to grips with. It's easy to understand. I also think that the current kind of way in which technology is moving and the issue of texting has improved contact significantly. We now get numerous reminders about appointments. So there's no excuse on behalf of the patient, as I see it, to have missed appointments because there are ample opportunities which come your way through text and messaging and emails to ensure that you do not miss critical kind of appointments. So I think that's quite critical. However, I do feel that there is somehow a disconnect in terms of the internal departmental ways in which each hospital appears to communicate. And this is where I think that there is some issues in terms of where there is no consensus in terms of the format. And I think this is quite critical. For example, and I highlight my own personal experiences. Recently, I had my referral letter come through, which was great. Yes, I've got a date. Within a period of a week, I had a letter from the physio department, and I thought, well, surely this comes afterwards. Mm-hmm. And the physio letter almost implied that I needed to contact them to arrange some form of physio. And it confused me because I was thinking, well, am I required to have some level of physio before I go for my pre-assessment? What is the situation here? And the headline at the bottom, which was quite kind of unnerving, said, if I don't make contact and don't make arrangements, then it'll be assumed that I no longer require services and it'll lead to cancellation. Now that rings alarm bells. Even somebody, and I think I'm quite an articulate guy, knowing at face value, this really only refers to the physio department, it creates that doubt in my mind. Is it going to cancel the whole process? Is my appointment now going to get cancelled? Is my procedure going to get cancelled? So you then find yourself having to ring round the various departments to kind of get to the bottom of this. And it creates anxiety. It creates doubt. It creates uncertainty. So I think the way in which letters are coordinated and sent out doesn't necessarily fall in tandem. And I understand that most of these are kind of computer generated, but it does create an awful lot of uncertainty within the patient itself, especially at the point at which you've got this high, you've had the appointment finally come through, and then you suddenly let down with this big doubt as to what's happening. And I think it creates a lot of anxiety, and I think it can create an awful lot of nervousness within the patient. And I think that can't be good from a mental health perspective. So I think there are matters that we need to learn from this. The other issue I would highlight is that post-operation, I was sent a survey, which is fine. You need to learn from my experiences, but it's the timing of the survey. I received the survey within 2 weeks of having had the operation. And it was asking me, it was a 10-page document, which was very detailed, and it was asking me quite a lot of kind of personal information, which is fine, about how I'm feeling, how the procedure went, what was good, what was bad. Now, within 2 weeks, when you're doused up in medication and you're still in quite a lot of pain, you're not in any position to answer those questions in a logical way, in my opinion. I think you have to have a time span of about 2 to 3 months before you can really get to the bottom of answering those questions correctly. And I think this is a particularly important point which I highlight, because those surveys are important. They're important to the NHS because you are going to decipher the content of the responses, and you're going to take those aspects which have been highlighted on board, and in the hope that you're going to improve services. Well, I can't see how you can do that if you're not getting a correct picture. And I'm having to respond as best as I can within a period of 2 weeks. Very critical kind of questions, which may not allude to an accurate kind of picture. So I think it's very critical that those surveys are sent out at an appropriate time. So the timing of the letters is quite critical, in my opinion. So whilst there have been general improvements in the way that the letters are formatted, I think the timing and the way in which and the nature that they are sent out doesn't necessarily fall in tandem. And I think it's a matter internally that the NHS and each hospital needs to resolve in terms of the kind of the liaison between the various departments and at what stage letters should be sent out, just to give that much better reassurance to the patient that things are falling into place now.
Raj,
the other aspect obviously is the face-to-face consultation. When you're within the hospital environment, within the clinical environment, and I again feel that services have improved no end. I believe there's been a significant improvement in the way in which you've dealt with, and I've seen that over the 2-year period. However, I think there's an issue for me. Clinical staff can be nice, they can be polite, but it's not the same as being empathetic in terms of how patients are dealt with. And I think this is quite critical. So I think there's inconsistencies in terms of staff skills, particularly in relation to one-to-one dialogue with patients. And there doesn't seem to be any coherence. You cannot apply a standardized approach to this because each patient is different and the needs of the patients need to be clearly understood before a clinician can respond in an appropriate manner. So I think that's quite important for me. And generally you sit there with a multitude of forms which the clinician is going through with you, and it becomes almost a tick box exercise, which is something I don't want. I want to understand the process. I want to understand the nature of the procedure. I want to understand the difficulties that I may encounter, and I want to understand, the potential kind of issues that may arise. So I need to understand all that, and I'm not getting that because there's, like I said, there's pressures on staff in terms of the amount of time allocated, and they're trying to get through an awful lot of work with you very quickly. And I get halfway through the pre-assessment consultation, and I think, can you please, mentally I'm thinking, can you please get to the last stage so I can sign the consent form, because you've reached a point where you've quite frankly had enough. And I think we need to get over that. I think there needs to be a certain skills base within staff which creates that empathy, which creates that dialogue between a patient and a clinician. And I don't think we're there yet.
And I think we're going to come to those solutions. And I'm going to come back to you, Raj, because I need to bring Matthew in. And I think, Raj, what you brought up there, that anxiety, doubt and uncertainty that you talk about, and that's not even about the operation. It's about whether you're going to have the operation. So that must be troubled. And I think your comments around patient experience and outcomes, and I think that's absolutely, we should be measuring the impact of your ability to get on with your life post your operation rather and you can't do that 2 weeks after the operation. And I think what you've talked about, that face-to-face and that shared decision making, which we have done a few seminars on this week around how we can work together as partners in our care, which is really important, and it's obviously very important to you. Matthew, I want to come to you because we've got to get to some solutions. How does all of this resonate with you?
So I always kind of think of communication a bit like as a child playing with a spirograph. You move around a lot and you're doing a big journey, but you don't actually seem to get anywhere. And I think that's how we can sum up communication within the NHS. If you look at most trusts, it's probably in their top 3 complaints every year. It's around communication. It doesn't seem to change. It seems to be almost a constant. So I think it is talked about in little areas and individually, but it doesn't have that national steer. It doesn't have a national approach to fixing it. And I think that's why communication doesn't seem to improve overall. I do see, and one of my examples would be, I remember having a secondary care mental health assessment in my GP practice. At the end of it, they went, okay, you do need their support. It'll be a routine referral. You'll hear within 12 weeks. 2 days later, there were mental health specialists knocking on my door because it had gone sent through as urgent, asked me why I'd not attended my appointment because I got the letter after when the appointment was, because it was done as urgent. You'd have thought there'd been some communication of, we've told you it's 12 weeks, but we actually have changed our mind. Someone's going to be in touch with you much quicker. That would have been a really nice point. But why is someone sending me a letter when they know my appointment's probably the next day and I won't receive it in time? And it's kind of, it just seemed totally baffling. And then it also put me off wanting to engage with them because I felt I was wrong. Like, and then I find like, am I more unwell than I am? I ended up going to A&E because I felt I must be in a crisis and I'm not realising it. I must need emergency help. And then I'm sat in A&E where I didn't feel like I needed to be. I felt an imposter being there, but like, well, the NHS are telling me that I must be really unwell, so I've come here because they're saying I can't cope. And that was just one example there. I can then bring up like when I was discharged from that service, when we're sending you back to your GP. It's like, well, I've never left my GP. I've always been going to see my GP. I've been with you for 6 years, but I've never left my GP. Then it's their wording. I end up showing it to my mum, like, Mum, it says if I have a crisis, I need to ring this, but if it's an emergency, I need to go to A&E. It's like, to me, a crisis is worse than an emergency. It's kind of like, why am I bringing a helpline if I'm in crisis, but if I'm in an emergency, I'm going to A&E? Like, what's the difference? And it's just that clear messaging, and I understand that they all have different patient record systems and they don't communicate well with each other, but why can't we have a set standard? If we're going to have contracts and allow people to have these record systems, why don't we have a set minimum standard of they can all send out texts, they can communicate with each other, even if it's just a basic summary, because at least then, no matter who you're talking to, they'll all have that basic understanding and they can all help you feel included within that conversation. And if it is that minimum standard, I could look at it myself on the NHS app. I kind of don't need to speak to someone if I can find it myself, but you need to give me the ability to be able to do that. And another example, some of what we've been doing locally in West Yorkshire recently has been some of our discharge letters, because it almost felt like it was telling me what I need to tell my GP to write to actually be able to access the service. Whereas, why are you sending me that letter? And why am I being discharged because the professional's not filled it incorrectly? Why aren't you putting it on hold while you find out these answers? And why is it my responsibility to do that? There should be a way of, or why isn't it simply, what's causing a GP to feel they can't manage my care themselves? What extra support does that person need? Why is it my responsibility to try and do all that communication? Especially when you have a lot of people who, because of the side effects of their medication, because of mental health, because of neurodiversity, struggle with communication, struggle with remembering what's been said. Why can't it just be a simple standard of, we'll give you a basic summary of what's been discussed or what the next steps are? Because even if someone can remember, they're not going to be offended by that. It's not going to offend anyone by having a simple summary of what's been discussed, and they're already making notes. Why can't that just be an easy shared system? And why can't it be written in a way that is plain English for everyone, because no matter what you do, you're going to understand a plain English summary, whether you are that specialist, whether you're the support. And there's a lot of work going on. There's a lot of work going on around communication and improving it, but it all seems to be local, and it's local fixes, but those local systems don't talk to each other. And it almost feels like the lowest it should be is an integrated care board level, because at least it's doing it for that small region. But you've got people in fit across both, 2 or 3. So that doesn't even really work for a lot of people. So it almost feels like it does need to be that higher level, but it needs to be more than just the NHS. You need to be bringing in social care, because you don't fix one without the other. We integrate it in everything else, but our communication doesn't.
No. And Matthew, you're so right about the point, everything you said, but the point about language and plain messaging, and again, our helpline will hear that, and we hear it through our focus groups. You know, and just that really good point around emergency and crisis, like define what we mean and have that consistent across the board. And one of the things you talked about is then you feeling that you have all the responsibility for coordinating your care. And Raj, you talked about that too, about, you know, getting that physio letter and having that anxiety about, does that mean your NEOP's going to be cancelled? And who do you have to tell, Matthew? And who, you know, Miriam, I'm going to come to you, because if I remember correctly, one of the recommendations in I Love the NHS was around care navigation.
Yeah. So after we kind of identified that communication was this like second biggest problem that people said was not right in the NHS, we wanted to look at what the solutions are, because it does feel like, well, that's the next step. So, okay, so what are we going to do about it? So we worked with Imperial College Health Partners to look for the examples of good practice. And then we put those in front of a group of patients that the Patient Association pulled together for us, people with complex health needs. And we worked with a group of GP practice managers, and we worked with our citizen assembly participants, just to go, right, well, the NHS thinks these things are working really well. Do they? Do they actually fix some of the issues that you're talking about? So we looked at those in detail, and then our groups came up with 3 recommendations that they said, look, these things would actually make a difference. And one of those, you're absolutely right, was about care navigation. So we know that care navigators exist in some GP surgeries for sure, but it's not universal and it's not consistent. But what people want from that care navigator person, it's the person who picks up the phone in the GP surgery. They want that person to be able to help them navigate the whole system, not just feel like that person is blocking them from actually talking to the GP. People do understand that is part of the, you know, there's a role that might be, actually, I'm going to point you somewhere else instead of the GP. Fair enough. But they want that person who picks up the phone to understand the system, be able to go, I will help you. I'll help you find your referral. I will help you know who to call in the hospital to know what happens next. But at the moment, because that join between primary and secondary care is often where the breakdown's happening. But a lot of what people said is like, but we don't really trust. We don't really have trust in that person to be able to do that role. So there has to be a lot of work done to build that trust. People don't want to see it's like just the receptionist, because that receptionist is the front line and they're incredibly important, but they need support and training to be able to do that job really, really well. So people feel like, well, am I just telling this like random person who doesn't know anything clinical at all? I don't want to tell them my intimate problems. Actually, this doesn't feel comfortable. So there's a lot of work to be done about, actually, what is that role? How do we explain that role to patients differently? How do we train that person to be able to do it really, really well? So that felt like one of those really critical points in the system where somebody could really, really, really help. Do you want me to go on to the other couple of solutions?
Just hold on for 1 second, Miriam, because I think the care navigation, there's a lot. So there was in the primary care transformation plan the promise to expand the role of social prescribing care navigating. And Matthew and Raj, both you are and there's a lot of questions in there around in the Q&A around, you know, why do GPs send clinical, you know, how do we make sure patients understand what actually has been said in letters? And Raj, both of you and Matthew, and I'm going to ask you to be quick because I do want to get on to the rest of the recommendations. Would that role of care, have you experienced the role of care navigator? And do you think that that would have helped in both your experiences? And Matthew, I'm going to come to you first.
So I have used the care navigator, especially around the mental health side within primary care.
Yeah.
Up educating them. It felt like it was very much, you had a list. And I think part of the problem locally was GPs created their own. So it was postcode lottery, which PCN you were under did it differently. And they didn't know what they had locally. I got much better support going to the voluntary care sector than trying to get it from the NHS. So it put me off care navigators at that point. I think it's that we need a uniformed approach, so we're getting rid of that postcode lottery.
Yeah, absolute consistency. And in a piece of work we did at the British Red Cross, the whole role of the voluntary sector. But actually, Matthew, you know the voluntary sector exists. A lot of people don't realise the support they can get. So that needs to be part of the overall strategy for communication. Raj, what's your view there? Did you ever get offered care navigation or?
No, I must admit I haven't, and my own personal experiences in terms of dealing with frontline staff is really quite poor. And I think there's an awful lot of work that needs to be done on that front, particularly at the primary care level in GP practices. I think there needs to be, as Matthew has already echoed, a standardized approach. You can't have this being wheeled out on a piecemeal ad hoc basis with independent surgeries running their own kind of systems and services as they see appropriate. I think there needs to be a standardized format, which people can buy into. I think there is a role for care navigators, but I think it needs to be clearly defined in terms of what that role is. And I think there's an awful lot of work that the NHS certainly needs to do on that front.
Yeah. Okay. So one of those recommendations still stand, Miriam, because I'm seeing that coming up in the chat box as well. So sorry, Miriam, I'll come back to you now for the rest of the recommendations.
Cool. And I'll go quick. So the second one was when we talked to patients with complex needs, they said, look, being a patient, it's a full-time job, like trying to coordinate my appointments, chasing up kind of referrals, knowing which medication to take when, knowing they don't interact. It's like, I'm the patient. I don't want to be that linchpin that holds it all together. I want somebody who is going to kind of be that single point of contact for these unbelievably complicated systems that really don't talk to each other. And the model that people really liked was the idea of a care coordinator, somebody who could just not for everybody, not everybody needs that, but if you've got really, really complex long-term conditions, a care coordinator who's going to just manage all of those different bits of the system for you, so you're not doing it yourself. And the third piece was around for people who just use the NHS, occasionally, just make the app really good, the NHS app. Please, could we just have something that will enable me to kind of manage my referrals, schedule and track my appointments, see my health record? Come on, apps exist, they're really good. Please could this just work really, really well, so I don't have to be phoning somebody. It's all just in one place, a single point of entry. The NHS app makes sense. A lot of people kind of use it and have access to it. Could that just actually work really, really well? So those were quite practical things. But the other thing that we heard, and the ultimate conclusion that we came to is if what we're saying is that you need better people to help you navigate a better map for the system, there might be something wrong with the system. It's so unbelievably complicated that actually a better map isn't the answer. Maybe there just should be simpler ways through it so people could just feel like it was on their side and working with them, rather than being something that had to be navigated that becomes really difficult. You need somebody special to help you kind of work your way through it. So just like a better map or better navigator feels like a sticky plaster, kind of the wrong answer. And then the other point was just about thinking about your kind of administrative staff and the receptionist, or the kind of those kind of back office functions, just how critical they are. And it's not bureaucracy that we should be getting rid of, not red tape we should be getting rid of. It's just fundamental to the system working really well. Please, could there be a more investment in those people so that there's enough staff to make it work better, and that the systems join up? Because I'm just reading the chat with people, it's really clear from the chat and from people that we spoke to, it's just the systems don't join. Area to area systems, they're literally on different computer systems. They don't talk to each other. Primary care to secondary care, the systems are different. They don't talk to each other. None of this works really well. please can we just invest in making those kind of the people, invest in the people so there's enough administrative staff to do the job really well, and the systems, much harder problem to deal with, but ensuring that the systems join up and are universal and consistent in a way that they're just not at the moment.
There's a lot to be done then, really, isn't there?
Yeah.
and I think everyone in there, in the chat and in the Q&A, and I think we're here. So what I'm hearing is that there needs to be something around patient experience that can inform feedback, that can inform communication and the development nationally of accessible, plain English communication. We've seen in the Q&A people talking about letters turning up on the day about your appointment, and then your med feel bad because you don't turn up for your appointment. Or Matthew, your dreadful experience and how scared you must have been to have two people just turning up at your doorstep and putting you into a crisis. And I think in the chat somebody put in, which I thought was really interesting, is the NHS is one of the few places left where you can't kind of choose your own appointment, you know, that you can't log in and go, here's a few appointments. And when we did work with them around why people didn't turn up, we talked about, you know, is there a bus route that can actually get there on time for that appointment? Have they received the letter? Because we know people don't receive the letters in time. Have you communicated with them well? Have you heard from them? All of these things about understanding, you know, do they have childcare commitments? There's somebody on there talking about his son's appointments, having 4 or 5 appointments coming up. And I've heard from people where the appointments are at different parts of the hospital. Well, they can't get there. So it's not joined up. Raj, how do you think patient experience outcomes, because you mentioned your surveys, how do you think patient feedback can improve NHS communications?
I think there is a need, whilst we're going through this process, to have some element of focus groups built in specific areas. I think the issue of the survey is quite critical for me. And I think it's something that patients will respond to, but I think it has a lot to do with the timing. And it's quite critical. In my case, having received something within 2 weeks of my procedure, and having to kind of decipher through quite a lengthy document and respond to questions which I felt were not really relevant to me because I hadn't gone through the process in terms of how I can actually gauge how the procedure went. You know, so I was putting in information which I thought was correct, but in essence it isn't correct because I'm not providing the right information. So I think it's very critical that the NHS gets to a point where the information that it receives or is able to receive from the patient is correct and accurate. And I don't think that is happening at the present moment. So I think you're building up an inaccurate picture.
So how can we improve on an inaccurate picture?
Yeah, I think, like I said, you know, it has to do with the timing. In my case, certainly the timing. If it had allowed me 2-3 months, after which I needed to respond, then I would have provided a much better picture in terms of how we go about, responding. And it would have provided me with a much more kind of comforting reassurance that I've been kind of correct in my responses. So I think that there is an element of timing within all of this.
I think you're right. Yeah, I think you're.
And I think it's quite critical. I think there are other areas in which we can, get at information. In my work life, I've used focus groups on a number of occasions to get at information on critical points.
Yeah, we love a good focus group.
Yeah. So it's specific, honing in on very, very specific issues that have arisen, and it's concentrating on those where you can really get to the bottom end of the problem. So I think there is an ongoing. This isn't something which you can kind of deal with now, come up with a list of recommendations and park that document in the hope that people are going to take this on board. This is a continual process of improvement. And it's a continual process in which you have to engage regularly with your clients, which are your patients. And I think that has to be done, not ad hoc piecemeal. It has to be done on a consistent, regular basis.
Yes, absolutely. You're completely right. And Matthew, I know I spoke to you before on another focus group we did. We talked about patient feedback and when patient feedback is when you receive the request to give feedback. So I don't know if you've anything to add to that, but I was going to specifically ask you as well about whether you have used the NHS app.
I have used the NHS app, and I'm also carer for 2 different people. But because we're under different GP surgeries, I have to register under different email addresses. So I'll get a text because you'll have the same mobile number saying, you've got a message. I have to log into 3 different ones because they all decided to use the same company patches to do it all. But I can only have my email registered once. So because we're under 3 different practices, you can't link the accounts. But the NHS app tells me if you're a carer, you can get it linked, but only if it's the same practice because they don't talk to each other. So the app doesn't work because of it. And not every service uses it. So I can see referral letters from some services and not others. And it comes in handy because I've gone to my GP and I've been able to show them my test results from the hospital because the GP hasn't received them yet. So it does have uses, but I still think of it as it were really good when I needed it to show my COVID rights and what I've done. But the rest of the app doesn't seem to have improved. It's kind of like in 2 years, what's improved with that app? Half stuff I can't even order for repeat prescriptions. It doesn't allow me. It tells me I can book an appointment, but when I go to book it, your practice has not allowed this.
That is a big issue, isn't it? The consistency across GP practices about what they're releasing out in the app. And I think there is plans coming to make sure that that happens. But your point about being a carer as well, I've heard that so often, and I've raised it quite often with people on the NHS app team, and they promised me that was there or was coming, but obviously not if you're in different GP practices. And I think that goes back to that issue that Raj, you brought up, and Matthew, I think you said, which you can't have local communication protocols. You have to have them at a level of ICS, at least that's what happens. And we did work with NHS England on some communication principles during COVID to look at how they could support ICSs to develop that. So rather than being this big national down thing. So I'm going to come back to both of you in a second, and you're going to both hopefully have a solution for me, but it's going to be a quick solution. And I want to come back to Miriam and just look at, I just wonder if you had a view at Demos around, I said at the very beginning about this communication thing often being seen as soft skills and not being hardwired into education and training. What's your view on what we could do system-wide? Because I think there's people in the chat saying the app works for me. Other people are going, the app doesn't work. Some people are saying, I need paper. I don't work with technology. And that's okay. That's their right too. That's what we have to do. Do you have views on all of that?
I think one of the worst things is when it feels like a postcode lottery, when it feels like, because actually I have to say the app works really well for me. Like where I live in North London, it actually feels really good. I'm like, oh my God, it worked. And it's a bit surprising. But we know that it definitely doesn't work because it's like I say, it's up to individual GP practices. And I kind of get that there is a system, there's a reason behind that. But you don't care as a patient. I don't care that it turns out that GPs are actually independent. It's like, I don't care. I just want it to work. And it shouldn't matter where I live. So I think there's a tension between it should be consistent, universal, standardized, but also locally responsive. And I really get that as I say that, it's like, well, those two things can be in tension, right? It's quite hard to make something that is like really, it makes sense for your local area, that works for your local context, but also be exactly the same all over the country. But at the moment, the difference, the variation feels unacceptable. It's completely unacceptable. And the system is it feels so incapable of dealing with the fact that's like, well, look, we've given you an app, so take the app. It's like, that doesn't work for me, or I don't want it on tech. I want a piece of paper, please. The system needs to be able to respond to actual human needs. So I think the answer always has to be human first, patient first. Like, really what's going to work. Start there and build out from that point, because at the moment, any other system is just not working for people.
Good. Okay, we're coming to the end, and I've given you two, Raj and Matthew, a heads up that I want to hear. You know, what is the thing you think they can do? Miriam, I'm coming to you too, so you need to be ready for that as well. So, Matthew, what is the thing you think? The thing we could do that makes this better?
I think there is that place for involving patients, but I think the issue becomes around that trust. I think when it becomes patient-led, initially without any buy-in from that leadership within the NHS, other patients then don't necessarily have the trust that the NHS will do it. And we need that buy-in equally. It don't need to be led by anyone. We need to be leading it together. It needs to be co-led and co-designed so it works for the people. And if you have a minimum standard, you can then there's no ceiling then. You can go wherever you want and you can make it work for that community. But everywhere should have that minimum standard. Instead of trying to break through a glass ceiling, why don't we just have a concrete floor?
A wonderful solution. Okay, Raj, what's your thing?
Just to touch on what Matthew's just kind of said, yes, it needs to be a partnership between the client and the service provider, and I think that's quite critical. I don't think it needs to be led purely by the NHS. I think it does need to be a genuine partnership, so you get buy-in from the client as well. If there is mutual trust and acceptance on both sides, then things are going to be a lot more smoother in terms of how we move forward with all of this. And that's a very kind of overarching statement, but it's relevant and it's valid. It needs that buy-in from both sides for it to move forward. I think in terms of improving communication specifically, I think there are internal kind of dynamics which do need to be resolved. The internal coordination and the linkages, whether it's with regard to IT or interdepartmental work, it needs to be done. So there is a coordinated approach. And I think this is where one of the key missing links is for me. There is no coordinated approach in terms of, correspondence, in terms of people experiencing, differences in how letters are received, communication is received, how verbal communication is applied. So I think these are internal dynamics, training for staff. These are the issues for me, which are critical in terms of moving forward and improving services.
Brilliant. And Miriam?
Basically what they said, what Matthew and Raj said, 100% agree. And definitely designing the systems with patients to make sure they actually work for people. The only thing I'd add is that I want this to be seen as important politically by the NHS. I want poor communications and sorting it out to be like right up there at the top of the agenda alongside waiting lists. Because this stuff is really, really important. And until it's being talked about and seen as a priority, it's just admin, it's just letters. It's not important as long as we're treating people, and that's the most important thing, and it should be a priority.
Completely. So, okay, we have heard so much from you there, and I think without me priming you whatsoever, patient partnership is what we're looking for here, and patient partnership in the design and delivery of services, but also in that individual shared decision making. And some of you may know, but we've got a new animation on our website around shared decision making that you might be interested in. And Sarah, one of my colleagues, because we talked about accessible standards, has just put up a copy of our jargon busting dictionary that we developed a couple of years ago, and we keep adding to. So if anyone wants to add anything to that, let us know. So I think the call to action that we have from this is, and Sarah's on here, who's spoken with us before, and she is the patient partnership guru, and she's saying everything on here that you're saying as well. So I think what we've heard, the call to actions, is that the government take this seriously. That, you know, we have Professor Lord Darzi, looking at his reviews into what's wrong with the NHS, doing his diagnostic, as he calls himself, and we've been sending information in around experience and measuring outcomes, and through that we hopefully will get better communication. But I think the other bit that's come out of it is that trust. Raj, both you and Matthew have talked quite a lot in here today around trust in the system, that everything is co-led and co-designed with mutual trust. But all of that is great, and we hope that that can happen. Raj, I think you're completely right. And tomorrow morning, we're having another session about the use of sedation, joining up services around patients. You cannot be a patient where primary and secondary care is not talking to each other properly, or where individual departments within secondary care are not talking. This is, you know, it does not need to be your full-time job to achieve good outcomes for health. I think we're going to take all those actions and hopefully reflect them in the conversations that we'll have. We're going into a period where the long-term plan is about to be designed, and we're already talking to officials about how they might do that and how they will do that. And I'm hearing great commitment to doing that in partnership. We'll watch that space, but I'm going to take everything that I've heard from you today, but also everything the chat has been really busy. It's been fabulous. We've learned so much, Miriam. I'm sure you're going to take it at Demos as well. All the stuff we've heard here today, to think about what our next steps might be, and maybe we can do some of those steps together, Miriam. So I think that leaves me to just thank you all so much for getting up so early. I know we're all up early, but you've had to, you know, put on your face to get out here and do this today. I hope that something will come out of it too, Marion, and we will continue to do our best through our helpline and our important focus groups and our representations to NHS and the government to try and take all of this on board and achieve something different for patients. Thank you so much.
It's been a pleasure. Thank you.
Thank you so much for having us.
You're very welcome. So thank you for attending. Here are some more information. We do have an event tomorrow morning if you want to sign up for that. And otherwise, I hope to see you all at another event soon.